Hi, it's Dr. Centeno, and thanks for taking the time out of your day to watch You've Got the Power. Today, we're going to talk about something a little different. A patient had approached me and asked me to do something on the difference between all of the treatments out there that are called stem cells. And, I realized that even though I've blogged on this topic many times, I've got a lot of different videos through the years, I hadn't done anything like this in a while. So it was time to update all of that. And, even if you've got cervical instability, you're going to be in a situation where someone's going to offer you some sort of regenerative medicine treatment for that, it seems like. And so you should know what the difference between all of those treatments is and isn't. At the same time, if you've got another problem, a shoulder problem, a back problem, an ankle problem, same thing. So we're going to get into the difference between all the treatments called stem cells. And so I will go ahead and share my screen here. Okay, so screen is being shared. I will get into now this topic from the beginning. So again, let me just get a pen here. So what's the difference between all of the treatments called stem cells? Doesn't really matter what you're getting treated. You're going to get offered a lot of different things. So let's go through that. So these are the references. Now, there's a lot of references for this one. There's probably things on here that I used that I didn't even include in the references. But so pretty research intensive topic. So the biggest problem in this space is there's no or very little education on these topics for physicians in residency or fellowships. And so most physicians get this education from weekend courses that are often sponsored by specific product manufacturers trying to sell one thing over another. So as you might imagine, they don't really have a deep knowledge of all this. They haven't read all of these studies to form their own opinions. They just went to a course where someone was trying to sell them something. Now, by my background in this area, I'm the first physician on earth to use culture-expanded mesenchymal stem cells for orthopedic problems way back in 2005. I published a good chunk of the clinical and lab research in this field, and I've established interventional orthobiologic education programs, including a fellowship. So I'm going to give you some broad opening statements that you can derive from the stem cell research. And then I'm going to go into each of these different stem cell types individually. So the first is that the role of a stem cell is a general contractor who can call in the subcontractors, meaning other cells, to get the repair job done, and then ideally turn into or differentiate into the bricks and the mortar. So it's kind of a strange duality. Now, stem or progenitor cells live in every tissue of your body, and this is how your body fixes small amount of local damage. If you're still alive, you have working stem cells that are doing this every single day. Now, this is a key one because the closer the role in the body that a stem cell served to its intended use, the better it works. So, for example, the fat stem cells in your belly fat don't have much to do with maintaining your joints or maintaining your tendons or maintaining your ligaments. So they're not going to be as good as bone marrow stem cells that are involved in all three of those functions. Now that's for that specific purpose. They might be even better for other things. Also realize that stem cell dose is a threshold phenomenon. In general, once you get past a certain dose, more cells probably aren't going to add more bang for your buck. And there's two big types of stem cells out there. You've got allogeneic, in this case talking about mesenchymal stem cells, from somebody else. So these are immunoinvasive or evasive. So that means that they can kind of trick out one part of the immune system to go undetected for a few days, but eventually they get detected by the cellular immune response. So they are destroyed by your body. Hence, these can only work through paracrine, meaning giving off certain growth factors and cytokines between the time they're reduced and the time they get killed off by the body. They don't survive to differentiate into other tissues. Now, autologous MSCs, those are from you, are not detected obviously as foreign. They can also excrete cytokines and growth factors, and they can also differentiate into the needed tissues because they're not getting taken out by your immune system. They're your cells. Now, realize that fat is a reservoir for lots of bad stuff. Bone marrow less so, but this is still an issue with really all autologous products. For instance, some of the thinnest people out there would be the best candidates for adipose stem cells because they don't have a bunch of inflammatory cytokines lurking in their fat. The average American with metabolic syndrome who's overweight and middle-aged has lots of inflammatory cytokines. So it's kind of a catch-22. The skinniest people out there probably do the best with fat stem cells, and the fattest people out there probably do the worst with fat stem cells based on this kind of stuff. In addition, fat's a reservoir for environmental chemicals that are organically based. So bottom line is, before you do any of this stuff, clean up your health as much as you are able. So now we're going to get into the types of products that are being sold as stem cell therapies. So this is the big map here. We've got someone else's stem cells over here. We've got your stem cells over there. And then you can see the two main types for allogeneic right now being sold in the US, umbilical cord, amniotic. And then as far as autologous, primarily bone marrow and adipose are the two we'll cover today because that's about 95% of what's used. So when it comes to autologous and bone marrow, you've got bone marrow concentrate, and then you've got culture expanded mesenchymal stem cells. Now, realize that they are illegal to use in the United States. The US considers those drugs that need a full cellular drug approval per clinical indication. One FDA approval for knee arthritis, another FDA approval for shoulder tendons, et cetera, et cetera. Now we go to adipose, and we've got three different types. We've got MFAT, we've got stromal vascular fraction, which is considered a drug, and we've got culture expanded mesenchymal stem cells. And then we go to allogeneic stem cells. We've got Wharton's jelly, cord blood, and then you can also culture expand or grow those cells to bigger numbers. And finally, we have amniotic, where we've got amniotic fluid and placental tissue. So now I'm going to go and dive into each one of these a little deeper. But before we do that, we have to learn some of the main cellular players out there. Mesenchymal stem cells I've talked about a little already, and they're sort of jack of all trades cells. They can act as a general contractor in the repair response. We've talked about that. And they can also differentiate if they're autologous. Then we go to hematopoietic stem cells. These are found primarily in bone marrow, and they can substitute for damaged muscle cells. They can also differentiate into other types of cells. So if you had a muscle or nerve problem, HSCs wouldn't be a bad thing to have available. Then we get into macrophages. In their M2 state, they act much like mesenchymal stem cells in that they can flip inflammation and turn off that inflammation switch to start repair. We've got mononuclear cells that are involved in cartilage repair and enhance the effects of PRP and do all sorts of other great things. So as you can see here, tissue repair takes a village, meaning it takes all of these cells working in concert to get to tissue repair. And this is something that we've learned more and more about as time goes on, that you need mesenchymal stem cells. Depending on the job, you might need hematopoietic stem cells. You definitely need macrophages to clean up all the junk and then start the process of repair. And you need these mononuclear cells as well. So let's start with bone marrow concentrate. This is the stem cell containing fraction isolated from bone marrow using a centrifuge. It's got all the cell types we talked about, lots of research behind it, good for all orthopedic issues. It's also got some really cool stuff called A2M, or alpha-2 macroglobulin. That's a really nice anti-inflammatory, exosomes, growth factors, and lots of robust safety data. Then we get into culture expanded bone marrow mesenchymal stem cells. Again, currently illegal to use in the United States. And this is where we take that bone marrow concentrate and then we further isolate it and grow it in culture until we get to a pure population of only mesenchymal stem cells. Now, it contains many, many times more, generally about 100 times more mesenchymal stem cells than bone marrow concentrate, but that's a little bit offset because it doesn't contain those other cells. There's some clinical research on it, good for lots of different orthopedic issues, exosomes and growth factors, and a pretty solid research base on safety. We've published much of that data. Then we've got MFAT, or microfragmented fat. That's fat that's chopped up very finely into microscopic pieces. The big problem with MFAT is that it's got very few free mesenchymal stem cells because they're locked in the collagen prison. So as you can see here, I've only added half a mesenchymal stem cell, but it does have the other two cell types, although fewer in number than bone marrow. There's a few clinical studies out there. Joint arthritis and tendons are kind of the focus, exosomes, growth factors, and some expanding research on safety. Then we get into adipose stromal vascular fraction. Now, this is currently a drug as considered by the FDA, so you're not permitted to use it. Doesn't mean you won't find clinics using it, but that clinic could be shut down at any moment by the US FDA for violating the law. And this is where we take those stem cells that we talked about in MFAT, but they're digested out using an enzyme. So they are now free. And because they're free, actually SVF has more mesenchymal stem cells than bone marrow, but fewer macrophages and other cells and fewer hematopoietic stem cells. So again, kind of a balanced thing there. There's been some pretty good research over the last 10 years. Again, the focus is more joint arthritis and tendons, exosome growth factors, and expanding safety profiles. You can also culture expand those adipose mesenchymal stem cells. So just like you could grow the bone marrow cells in culture, you can grow these in culture. And pretty much very similar to stromal vascular fraction, but you're just getting a lot more mesenchymal stem cells. And again, currently illegal for use in the United States. So make sure that you realize that. Now we're going to switch topics, and now we're talking about allogeneic stem cells. So Wharton's jelly, this is the structural jelly from the umbilical cord. The biggest issue here, and with all these birth tissue products I'm going to go over, is that we've done this research with the Colorado State University Translational Medicine Institute. It's been done at Cornell. It's been done at UC Davis. And the problem, UC Irvine. And the problem is that all of these cells are dead or dying when they are thawed in the clinic. So you're not getting any living cells here. There's very limited research in orthopedics. We really don't know what this is best for. It does have exosomes and growth factors, and that's probably how it works, just like PRP, although it's a very expensive version of PRP. Obviously, a limited safety profile. There's not a lot of research at all. Then we've got cord blood. This is blood from an umbilical cord. So we have dead and dying mesenchymal stem cells, just like we talked about in the last one. You're not going to get any living stem cells here. limited research. We don't know what it's good for. It's got some growth factors, which is probably how it works, just like PRP. Again, very expensive PRP, and limited research on safety profile. You can also culture expand those umbilical cord cells. The good news is if you do that, you get lots of MSCs like the other culture expanded products we were talking about, bone marrow and adipose. And there's some pretty good research in the orthopedic realm published over the last 10 years, mostly in Asia. It does have growth factors in exosomes, and there's some research on the safety profile. Still pretty new, but that's growing, and it's currently illegal for use in the US. And then finally, we've got amniotic fluid and placental tissue. Again, same thing. These are all dead cells when they come out, limited research. We don't know what it's good for. If it works through its exosomes and growth factors, and limited research on safety profile. So again, you probably saw a trend there, right? All these birth tissue cells being sold in the US were dead and dying. So at the end of the day, if you're looking for a live cell therapy, you wouldn't want to look to the left. You'd want to look to the right where you've got all these living cells. And in general, this is what you'll see. Legit providers understand this. They've been to all the courses, all the conferences, so they focus on bone marrow and adipose, whereas fringe providers focus on dead cell products and try to hawk those as live cell products. And this is just a big cellular comparison table just to go over what we just talked about. So we had bone marrow concentrate, has MSCs, got lots of HSCs, lots of macrophages, lots of mononuclear cells. MFAT, very few mesenchymal stem cells, because remember, they're locked in those collagen prisons. Stromal fraction has more mesenchymal stem cells than bone marrow, but bone marrow has more hematopoietic stem cells than SVF, more macrophages, and more mononuclear cells than SVF as well. And then we've got all the dead stuff over here, Wharton's jelly, amniotic tissue, lots of dead cells, but nothing that is surviving to culture in the peer-reviewed research. So in summary, it takes a village of cells to repair tissue. Those cells need to be close to the type of tissue you want repaired. Bone marrow and adipose cell therapies are the most used by legit providers. Each has its own benefits. Fringe providers tend to use birth tissue-derived cells, and in the US, those are not living, meaning they're not products with living and functional stem cell populations. So I think that's all I've got. I'll go to questions now, and I'll stop sharing and see what kind of questions we have. Okay, so questions. Yeah, thanks, Damien. I thought I'd do something a little different. So if you've got a question, guys, this is a great time to submit it. Stephanie, have you ever heard a patient complain about feeling the atlas moving, sliding, grinding with relatively simple activities, even saying still, I feel something at the base of the skull catching? We have. That's a pretty common complaint with CCI patients. It's been advanced by Harry Winston. Is there any difference between what we would be getting from you and algal cells here and other places here in the UK that say they're using stem cells? Well, algal cells know in that they're a Regenexx provider, so they use all the Regenexx protocols for cell isolation and concentration. Elsewhere in Europe, really goes back to the topic I just explored, meaning that a legit provider would use, on the stem cell side, bone marrow or adipose. And the good news, I think, in Europe is that you can get access to stromal fraction. In our experience, it works about as well as bone marrow concentrate. But same things that we just talked about in the presentation. It's been advanced by DB. I saw a doctor in Florida who said that the stem cells they were using from babies umbilical cords are the most powerful stem cells known to man. Is that true? No, that's a total scam. That's consumer fraud. And it's consumer fraud because we've tested lots and lots of Wharton's jelly umbilical cord and umbilical cord blood products, they're all dead. So if a provider is telling you that that's a living stem cell product, then the provider is totally scamming you. Now, there's only two possibilities there, right? One possibility is he knows what's going on. He's seen the research, and that's just outright consumer fraud because it's dishonest. The other is he doesn't know what he doesn't know, but neither one of them is very good. So I would go run out of that office and find another provider. It's been advanced by Sherry Kopp. Do you need to be very healthy to have good stem cells? I wouldn't say very healthy, Sherry, but you want to clean up all the stuff you can clean up. So, for example, we have a lot of patients in the U.S. that have metabolic syndrome, high blood pressure, extra weight, high triglycerides, poor blood sugar control. That kind of person would want to reduce their glycemic intake so that they could start to clean up some of those things, meaning reduce eating sugars. Elaine, sure, Elaine. Arno, I got a rotational MRI done, and the report says complete exposure of the C2 facets when looking left. Is that normal? Later states there's some signs of rotational instability. That's generally not normal, but you'd want to measure the rotational angles between C1 and C2 and calculate that angle, and then use that information against the published research by Dvorak et al. So anything above 56 degrees of C1, C2 rotation would be considered hypermobility. So if they didn't measure those angles, they need to be measured. We would obviously measure them if you were doing a consult or a telemedicine with me. And again, as I always say, I didn't put this in the slide today, I apologize. If you want or interested in a telemedicine for craniocervical instability, I just put Carla's, my assistant's email down there. You would want to reach out to Carla to get that done. John, looks like Coltrane across the board is legal. Thank you for sharing this. It's legal in the US, yes. Now, not in other countries. So Cayman Islands, it's allowed. So that's why we have a clinic that we license down there where we can bring patients. In parts of Asia, it's not illegal. But in the US and Europe, yes, it is. Hi, Dr. Centeno. Thank you for having these information sessions. How do you know the inability or instability is too severe for the PICL procedure, and why would that be a problem? The only way it would be too severe for PICL would be if there is enough damage where the ligament is torn in half and pulled back like a rubber band. Now, 99% of the time, even when there's very large amounts of instability, that's not the case. Now, there are other things where maybe there's too much physical pressure on a structure, like the brainstem. So I'd have to look at your films to comment. Elaine, can PICL procedure make you worse, paralyzed, or have more symptoms, never get better? What are the risks? Certainly, there's a risk of infection. That's the biggest one we're concerned about. Hasn't happened in almost 900 cases, but it's theoretically possible. It's also theoretically possible to give you a very prolonged flare-up. Longest ones seem to be in that 3 to 6 month range. That's increased symptoms for that time. Any procedure you can get, whether it's PICL or upper cervical fusion, has the potential to make you worse, although that would be rare. And as far as never get better, that's really impossible to say for something like that. Elaine, can stem cell therapy treat torn tendon, shoulder blades area, ribs, and thumbs? It can, but much of that depends on what those issues are and how severe they are. Elaine, which medication should you not take with stem cell therapy, and how long treatment before you have to stop them? For example, corticosteroids. Well, there's a very long list, so I can't go through the whole list here in this kind of format, but let's just take corticosteroids. You want to be off corticosteroids for 6 to 12 weeks prior to any kind of stem cell treatment, because that's going to hurt the cells. Elaine, how do you manage fluoroscopy in a patient that's allergic to iodine? Yeah, allergies to iodine aren't a thing when it comes to fluoroscopy contrast. What you're really thinking about is the type of iodine-based contrast they would use in IVP or kidney studies. But we see very little crossover between allergy to iodine and fluoroscopy dyes. For instance, I've got a pretty good iodine allergy. Can't have certain kinds of shellfish because of their iodine content. I've gotten multiple spine procedures with radiographic contrast that's iodated and never had an issue. Same thing in patients. John, can a change in cerebral spinal fluid pressure be a contributing factor to CCI? I wouldn't say a contributing factor, but more of something that can happen because of CCI. Fatchin, can centers that deal with post-concussion syndrome or vestibular insufficiency help patients with CCI? Certainly anyone that's dealing with the neurologic reflexes between the eyes and the upper neck can be very helpful in CCI patients. So to the extent that that center is focusing on that, then the answer is yes. Bethany, hi, Centeno. I know you stay away from disc replacement fusion at all costs. However, after my failed injections, 5/6 disc bulge, I think it's time to move to surgery. Yeah, Bethany, certainly there are patients who need surgery. The good news is it's a small percentage of patients who are told they have to have surgery. But there's definitely patients that do need it, usually with the bigger bulges when they're putting mechanical pressure on the spinal cord. And that's Carla's information there. So if you want to schedule a eval for craniocervical instability, Carla's the person to reach out to. Do not reach out to the call center. Do not reach out and fill out a form online. Carla can take care of you. That's all Carla's email address there. It's been advanced by Stephanie. I got stem cells from babies in California. Honestly, they did nothing to help. So in fact, I got a reaction was sent me to the ER. Yeah, you didn't get any stem cells from babies. Well, you didn't get any living cells. You got dead cells from babies. So you bring up an excellent point, which I didn't bring up in this presentation because it was already kind of long. But live stem cells from someone else are immunoinvasive enough where they're not going to provoke a graft versus host or graft versus host-like reaction, meaning a fulminant immune response to foreign tissue. But what we're seeing in these dead cell products, like the one you got in California, is that because the cells are dead, they're not immunoevasive. And the body does mount a pretty nasty mini graft versus host-like reaction. And so we've seen lots of patients end up in the ER from getting umbilical cord and amniotic products because they're dead. Had they been living, probably would have been less of an immune response. So you bring up a very important point that I didn't bring up here. Arno, the angle is 46 degrees, so normal range, but complete exposure of C2 facets. So we're wondering if steps obviously normal. Yeah, Arno, happy to look at the films. If it's only occurring on one side, then the other thing would be looking at whether or not there's a congenital side-to-side difference in how the C1, C2 facets are formed. That can happen. But again, happy to do a telemed, look at those films. Ultimately, an open mouth lateral bending view might be needed to act as a tiebreaker there, because there we'd be looking for overhang, which is the other representation of rotational instability at C1, C2 at least. Ulysses, where do muscle tensions start in the upper neck? Not quite sure how to answer that one. Can arthritis affect the whole body? Not very common. In order for it to affect the whole body, you generally have to have some sort of immune system type arthritis, like rheumatoid arthritis. And even then, it's usually not the whole body. Bobby, do you treat trigeminal neuralgia? We do. Within our clinic, Dr. Merkel, Jason Merkel at Centeno-Schultz, is an expert in treating that with interventional orthobiologics. There isn't much expertise on the Regenexx network in treating that problem, so you'd want to go see Dr. Merkel if that's your primary diagnosis. Now, if your primary diagnosis is craniocervical instability, then obviously I would end up treating that, and then if you needed a specific trigeminal procedure, that would go through Dr. Merkel. Ulysses, what contrast dye can see all nerves and blood vessels too? Not sure what you mean there. So iodated contrasts like Visipaque and Omnipaque are used sometimes in vessels. Usually Visipaque is used in vessels, not really nerves. Elaine, people with intracranial hypertension related to CCI, do they see their ICHT symptoms improve? Yes, in general, but realize a lot of what gets called intracranial hypertension is actually swelling in the upper cervical bursa, which causes that pressure kind of headache pain. But yes, in folks that do have legit intracranial hypertension, they generally report a reduction in those symptoms. Jingesh, does posterior subluxation of 3-on-4 at approximately 3 millimeters suggest ALL damage can be treated with interventional orthobiologics, or must it require surgical reduction? Yes, so that would be an anterior longitudinal ligament injection if that's causing symptoms. And that's a pretty tough procedure to do because you've got to use x-ray guidance plus ultrasound and avoid lots of important structures here in order to get to that area. But yes, it can be treated usually with interventional orthobiologics. Stephanie, anything indicated by a V-shaped ADI in neutral? It may be an indicator for instability, and I would need to look at the MRI to see if there's other small findings that are consistent with that. And then obviously we'd want to see what happens to that ADI inflection and extension to see if that's actually a transverse ligament problem causing too much movement between the dens and the atlas. Elaine, did a problem ever occur while doing DMX or after it because of severe instability? Not usually, no. So no, DMX shouldn't cause any issues like that. Arno, I have a internal jugular vein compression, both in neutral and motion, but if only issue that has been noted on my report states rotational instability, what causes the compression in neutral position. But just realize, Arno, a couple things. The first is that a lot of people who have no problems in clinical studies, about 1 in 3 to 1 in 5 patients with no issues at all related to internal jugular vein compression have compressed internal jugular veins on imaging. So there's that issue of possibly a false positive when it comes to causing symptoms. But if it is causing symptoms, then generally what can happen is that you can get forward displacement of C2, which could cause problems, or a rotational displacement of C1 on C2, because the C1, C2 joint is biconvex and one goes down the hill, so to speak, on the other, and that's going to push that portion of C2 into the internal jugular vein, often in the neutral position. Elaine, how many days do we need to stay close to the clinic in case of bad reaction to the treatment or else? I'm trying to figure out how many days I should plan for the trip. Yeah, so if you're coming from Europe, we'll usually ask the person to stay the whole week. So they'll be seen, let's say, on a Tuesday for the procedure, for eval, etc. And then that gives them a couple days to recover before they head back, a couple days to come back in the clinic if there's any issues where things need to be looked at. Rob, do you think providers of umbilical cord products should be telling patients informed consent about 1271 noncompliance? Yes, I do. Now, what Rob's bringing up is that I didn't really focus on it in this presentation, but the way umbilical cord products are being sold for use in orthopedic and spine problems, that makes them an illegal drug. And that may be confusing to you because there's two ways to get to an illegal drug. One would be the processing is beyond minimal, which many of these products are, but they're kind of right on that edge. The other way is if they're used in a non-homologous fashion, meaning that umbilical cord Wharton's jelly cells have nothing to do with knees. So if you use them in a knee and advertise it that way as the person selling that stuff, then you're violating FDA laws. So yes, they should inform providers of that. But as you know, many of the sales reps that work for these companies aren't the routine sales reps who really understand what you're talking about. Instead, in my experience, many of these sales reps' last jobs was used car salesman, bartender, etc. So they really don't know enough to ask the right questions. ZA, do I need any new imaging, MRI, CT scan, post-recent styloidectomy, or is my prior imaging still sufficient in regards to having posterior PRP? Well, first you have to get to a diagnosis, right? Because posterior PRP works for certain kinds of instability, but not others. So is it type 1A, B, C, or D? Type 2, A, B, or C? Type 3, A, or B, or C? So as you can see, there's about a dozen different kinds of craniocervical instability. Some of those would be helped by posterior PRP. Some of those not helped at all by posterior PRP, depending on what the ligament is that's damaged. So you'd need to get a diagnosis of CCI type before you'd even be considered a candidate for that kind of treatment. Right before a posterior PRP treatment, do you review the image data to account the patient's unique anatomy? Can their structure only be seen during fluoroscopy? Yes and yes. But again, first you have to get to a specific diagnosis of which ligaments are a problem. So that's that type A through D, type 1A through D, type 2 A through C, type 3 A through C. So those have to be applied from a diagnostic standpoint to understand which ligaments are damaged, to understand what kind of treatment would be effective, meaning that we may know beforehand that posterior PRP is not going to help at all. ZA, what would it mean if the motion of chewing somewhat relieved head pressure? What would the jaw motion have an effect in regards to vertebrae and ligaments? Not so much that, but I think what you're talking about there is this whole anterior muscular stabilization mechanism that can take over for ligaments and muscles that aren't working back here or in the middle. And so by clenching your jaw, you're probably providing some stability. Now, it's not real functional. You can't walk around with your jaw clenched all day, but it does seem to provide some stability. Katrina, I've heard of exosome-specific therapy. What's your opinion on this? Again, a bit of a scam in 2023. Exosomes are merely the language between cells. So if we were cells, me being a cell, you being a cell, the words I'm saying would be the exosomes. Now, those messages, those cellular messages, we would need to know more than we know today, because we'd have to take only the good messages and bottle those and throw away all the bad messages, right? Because the message may be, hey, help me repair this, or the message may be turn into a cancer cell, or I don't need you anymore, become apoptotic, which is to die. So it's a scam in that we don't know what those messages are in 2023. We do know that if we put a live stem cell on the ground, that live stem cell can detect what's needed and shoot out those exosomes that are appropriate to the scenario. But by getting rid of the cells and just using the exosomes, we don't know what the message is. Yolaine, there is no DMX in my country, so can we do a DMX in your clinic for the PICL? Yes, we do that all the time. Arno, how would you decompress an internal jugular vein compression? So it'd be that false negatives are very positive, but it's only a physical finding I have which aligns with my symptoms. Yeah, there's no reason to decompress it. It's the instability or the movement, if that's the issue, that's causing the problem. So the issue is to get stability back. Decompressing it, like through a styloidectomy, will only destabilize the anterior neck. So that's generally a bad idea in a patient who has craniocervical instability because we're taking away one of the stabilization mechanisms. So no need to decompress it like that. That's sort of 1960s surgical thinking and not 2023 thinking. Arno, is the styloidectomy an option to treat jugular vein compression if you don't have an elongated styloid? Not a good idea if you've got craniocervical instability because it's going to make it worse. Arno, how would you decompress? I think we got that one already. Lane, where can I find that list of medication to avoid stem cells therapy? Well, the first thing, Elaine, would be you would have to have a telemedicine. We would have to determine that you're a candidate for this procedure, and then you would get that information. Jonas, is traveling alone for PI from Europe an option, or would I need assistance? Definitely better to travel with assistance. We can get you a nurse, but that obviously there's a charge for that because you'll have to pay the nursing agency directly. So that you can get someone who could stay with you that first night and just act as your advocate in case there's any issues, problems, etc. But it may just be better to bring someone with you because that's not inexpensive. Elaine, where can I have the cost for stem cell therapy, imaging, etc.? Again, we don't know that that's what you need, so we'd have to do a telemedicine first, decide what it is you need, get to a specific diagnosis, which would decide where you need it, and then we would talk about what you might require as far as treatment. My jugular vein doesn't seem to be compressed in instability, as the report says that if there's instability, it's very mild, so I'm confused as to what's compressing if it's not the instability. There's 12 different types of cervical instability. Is it 12? 11? That tied to specific movements and specific ligaments. So we don't really know that you don't have instability at this point. We just know that with the limited imaging you had, that they didn't find instability in their mind or in what they were looking for. So I would suspect that we'd want to do a deeper dive there first. ZA, I had my telemed consultation with you, scans and imaging included, and a comprehensive posterior PRP has been suggested before the PI cell to make sure I didn't need new imaging. No. So in that case, no new imaging. Looks like we decided that posterior would be the way to go. Okay, guys, so I am out of questions here. We've got about 15 minutes left. Any questions out there that I haven't answered? Anyone want to bring anything up, whether it's about this topic or another topic, doesn't really make a difference to me. Any others? Here's one. Jing Nesh, is it possible to have alar transverse injury when MRI doesn't show any disc protrusion at C2-3, but disc protrusion present at C3 through 6? Yeah, cervical MRI is not going to show alar transverse ligament. So you're barking up the wrong tree if you're trying to use a routine cervical MRI to show an injury to those ligaments. Now, sometimes there are things on the cervical MRI, if read by an expert, but not by a reading radiologist in general, that can show evidence of possible craniocervical instability, but we're not looking at the discs to determine that in general. So a routine cervical MRI is unlikely to show what it is you're trying to get to, or at least what you're trying to rule out. Arno, is it normal to have jugular vein compressed when rotating? It is. They get compressed all the time. When you turn your head, they get compressed, etc. So that's one of the problems here with the diagnosis, right? We have a lot of people we know who are normal, who have no symptoms, who have compressed internal jugular veins. So Arno, I would be really, really focused on trying to do a full workup for craniocervical instability before you hang your hat on internal jugular vein compression. Can you disclose the general cost of a consultation if insurance doesn't cover? Carla can get you that information. So just her information or email I put in the comments. So reach out to Carla and she can get you that cost. Sure. Katrina, are you familiar with wherever Dana White had to recover from Meniere's? He had it done in Germany, had to do it drawing blood, 32 ounces and reinserting it. Yeah, that's probably just platelet-rich plasma. So, and it probably wasn't Meniere's. It was probably upper cervical related or cervicogenic dizziness. So PRP, super common. Nothing about it that's more sophisticated in Germany. In fact, most of the European PRP systems are pretty weak, meaning they produce low quality PRP compared to most of the American systems. Sure. Okay, guys, any other questions I can answer? I'll wait a couple seconds. So just to start wrapping up what we talked about today. So we talked about the differences in all of these, quote, stem cell therapies. Some of them have stem cells, some of them don't have any living cells. And just to try to educate you as the consumer to make sure you know what it is you're buying. Kyle, how would you recommend stem cell injections? Would you recommend stem cell injections for degenerative disc disease causing sciatica? Usually not needed. Usually platelet-based treatments do very well there, depending on what's wrong. So again, there could be 10 different types of degenerative disc disease. First, you have to get to that diagnosis. Then that diagnosis tells what you need. But degenerative disc disease is just too big a box where there's specific things in there that would be a candidate and would not be a candidate for interventional orthobiologics. ZA, what craniocervical ligaments have the most impact on eustachian tubes causing dysfunction? None of them have a great impact on eustachian tubes. Now, if you had some sort of anterior instability, might cause a little bit more irritation of eustachian tubes. And obviously lots of other things. Now, there can be irritation of specific small nerves that might show up as irritation of eustachian tubes, nerves that might get irritated with a type 2B instability or C1, C2 overhang. Fatchen, if some ligament is more loose, can a head tilt in a specific direction? Usually it would have to be very loose for that. Usually the head tilts are proprioceptive or position sense base. Sure, Jingash. Katrina, what do you list insurances you take on your website? We do. Now, the procedures we're talking about, none of which are covered by insurance unless you're covered through one of the Regenix companies. There's now 1,200 companies that have signed on with Regenix to cover this stuff. But if you're not covered through that, United Healthcare, Medicare, not going to cover this stuff. We're in a lot of insurance plans, so we can take insurance for things like in-office visits. So that's something that we generally take insurance for. Okay, I think we're running out of questions here. So guys, I want to thank you for your time today. I know this was a little bit of a longer topic, but because there's a lot to cover there and I didn't even cover it all. So let me know if you want me to do more stuff like this, less stuff like this. There's a potential part 2 that I can do to this video talking about things like PRP, exosomes, growth factors, etc. So you let me know if you'd like to see something like that. And then Katrina, not on the website, but if you contact the Regenix call center, they can check it against their list. Ara Juarez, can PRP help with tendonitis on wrist formation or forearm inflammation? In general, yes. Pia, or stuff like this. Sure. So just to let you know, I won't be here this Friday. I've got a national conference in Phoenix I'm lecturing at. And so it'll be too hard to break away from that and do a Facebook Live. But I will be here this coming Monday. And I'm probably going to do another CCI topic then Then I'll mix in a non-CCI topic like this, maybe on off weeks. And at that point, I'm already working on that topic as we speak. And just so that you know, so that's not this Friday, but a week from today, I'm going to lecture on alar ligament laxity and rotational instability, type 2B CCI. You've heard me say that a lot. Type 1, type 2, type 3. This is type 2B. And it's that side-to-side alar ligament instability. So I'll be lecturing on that, giving both a way that you can make that diagnosis in Europe, and you can make that diagnosis with the DMX in the United States. So that's a week from today. Again, I won't be here this Friday. I'm lecturing at a big conference, but I will be here a week from today. So you guys have a great week. Thank you for all the great questions, and I will see you a week from today. Thank you.